Hi everyone. Hope you're doing good. The last session was indeed so exciting. I had put the translated captions on, and it's really so cool thing I have seen, this year. So yeah, it feels good to be included. And I am Rag Malhotra, and today I would be talking about the inherited expectations and embodied healing for treating postpartum depression and anxiety in South Asian moms. And when I say South Asian moms, it's basically, the core eight from the people from India, Pakistan, Bangladesh, Sri Lanka, Nepal, Bhutan, Maldives, and sometimes Afghanistan. Sometimes they're included, and sometimes it is not. And so, being in the US, so currently I am speaking from California, and so the Bay Area is filled with a lot of immigrants from India, and the population of South Asian is, I was just checking online, it is 5.4 million. And so that means there would be a lot of parents out there with their kids who might be looking for help, and they would be coming to you to ask for help. And now a bit about myself. So I wanted to tell you about myself clinically as well as, personally. So professionally, I have spent, 5+ years in perinatal mental health. And I am trained from India, which means that I grew up clinically inside the exact culture what we'll be talking about today. I'm also a mother of two beautiful kids, and both my pregnancies have been uh, very, a big turmoil. So, yeah, I had hyperemesis gravidium, which is severe morning sickness. And that was one of the reasons for my postpartum and anxiety and depression. So, when I say about this population is undertreated, I'm not just saying is as a clinician, but I am also saying it because I have been there and I did not know where to go through. So, and yes, that was the main reason I did my PMHC because back in India, I didn't find any therapist who held those credentials. And in today's presentation, we would be talking about by the end, you will be able to figure out what are the biological, psychological, cultural factors that, shape how postpartum distress shows up in South Asian moms. So you will recognize how, the family history works in the South Asian population, about the intensive mothering that shows up in the room. And you will be able to formulate a framework which actually works for them. What I call is the BPS cultural healing lens, that is biological, psychological, and cultural uh, the scenarios. And with that, we would be including what I call the maternal bodyfulness, which you can, use with your clients to as one of the healing concept. There are so many, but this is one of them which I use. Sorry. So when I say why is this population undertreated? To treat something well, we first need to understand why it keeps getting missed. There are basically three reasons, as you can see on the screen, which are consistently which show up. One is the screening tool, and it was not built for this population. Two, distress in this group often comes out through body, through relationship issues, or through silence, not through any emotional language. When we see our EPDS as a screening tool, it shows up lots of emotion, which is very great. But sometimes in the South Asian population, naming those emotions can bring up some shame or fear. So in a way, and so usually when we go for to our OBGYNs, that is where our first EPDS screening is done. Then we go to our therapist when our EPDS screening is done. You might see that there might be a family system, showing up with the patient or with the client announcing, and they would not open up much because the fear is that it would show up like the family has failed to take care and there is something wrong. So these are the three things that feed. they feed each other constantly. Now, in the next slide, what you see is a hypothetical example which has been shown up in very different forms in my practice. So, what I'm talking here is that sometimes the symptoms is not current. Sometimes the suffering is ancestral. We don't know what kind of trauma is being passed on from one generation to another. So, what this diagram shows is an example. So, meet Ananya. She's a 34-year-old, 3 months of CBT. She has an EPDS score of 11, which looks like a progress. And her therapist has encouraged. And now Ananya says, I know what to do, but I still feel that I am disappearing. Now, when you hear the statement, you can see that she's not treatment resistant, but she is carrying something from the treatment which hasn't touched base yet. So these are the five factors. One is the inherited maternal wound, self-erasure, impossible standards of motherhood, nervous system dysregulation, role captivity. These aren't symptoms, but they are grounded beneath the symptoms. So until we are just doing the partial work. So, like you see, this chart actually shows like for postpartum depression, general population, which is showed is 13%, whereas in the South Asian have reported only 9%. But the actual estimated is 22%. So that is 2.4 times greater. And that is why the EPDS, is failing. And there are basically three reasons for it. First is the family getting help often signals that there's a family failure. So women minimize it. Second, suffering is kept private. It has not even come to the thing where you can go to a clinician or a doctor to talk about it because, the more it's the way you stay silent, the more resilient it is considered. And the third is that this one that stays with me is a score of 9 on the EPDS doesn't mean she's fine. It means that she might, you have to ask her more questions where, she can connect from, what background she is coming from. So maybe, so what I have seen in the South Asian population is that women have learned to hide their pain very well. And I truly believe it needs to be named. So our job is to create a space where she can name it. It may be for the first time, but we have to give them the space to speak it. Next is when you see on the left-hand side is the standard care, which we are, trained for, like, to measure the mood, teach the coping skills as a therapist, aim for symptom remission. That is all good work. Very grateful for, to get the standard structure. But what I'm not, when you see on the right-hand side, these are the four, themes I have seen in the practice that the same symptoms are sitting on the above, correct? But underneath are the five root system that standard care has never taught us. For example, inherited wound, which is passed down through family norms and asks mother to disappear into caregiving. Impossible standards that create constant feeling of failure. Why am I not good enough? Why I am not able to manage it? So the years of stress that keep our nervous system struck. And the family roles are so rigid, there is no room to move. So when we treat only the symptoms, what you see, we just get the symptom relief. But when we reach the roots of it, we get something totally different and beautiful. We interrupt the pattern for her generation and the next, and that outcome is totally entirely different and very healing because it is very important to understand where we are coming from. Next is the three silent channels. So how does suffering move across various channels. So I have divided into three threads. So thread one is the attachment patterns. It says like the emotional habits the client has learned from being parented. What feelings got a response? When during her childhood, whenever she complained, whenever she was in distress, how did the family react during a particular situation? What did love actually sound in that family? What was named and what was left in silence plays a very important role. Second, you would see is the relational scripts, the unspoken rules about what a woman can feel and say. She may not know that she's following a script. She doesn't know that, but because that is what she has learned from being born till now, being her mother, that this is how the motherhood is supposed to be. Third is the epigenetic mechanism. This is where the biology gets remarkable, I would say. A parent's trauma history can shape a child response system before the child is even born. And the body inherits that words can't carry. And together, this explains why the birth can never be just a physical event. It, reactivates the wounds which have been there, in the present or in the unconscious, I would say, but those are the patterns we carry. And that is why it is very important to address these, the attachment patterns with the client had, what are the relational scripts the family carries, and the epigenetics, what is the family history. Moving on to the next slide. Now, so these are, I want you to see your client not as an individual, but as a bottom of a three-generation picture. So at the top, you see is a woman, is a grandmother who survived through silence, migration, loss, the rupture situation where endurance was the only option. And sacrifice became how, she expressed love because that is what she only knew. In the middle is the your client's mother who inherited the same script, who mothered by erasing herself. And I say erasing herself, like, uh, who she is. Like if she has any question, she might be got dismissed. So there's no words to the question and no tools to change it. And then comes your client. In the postpartum period, when the birth has brought all these things together, she may have no idea why she's feeling this way. Now, the source isn't this pregnancy, it's pregnancy plus what she has been carrying. So, the birth, I always say with my clients that it reopens unfinished story from generations of women. And that is not poetry, it's literally the clinical observation. And that really needs to be there in our treatment planning. So these are the few questions. So what does this mean for our assessment? So here are the questions I carry into every session with the South Asian postpartum clients that, for example, what did she learn? So we have an EPDS, but we have to sometimes put these questions when we see our EPDS questions, and put these questions out. So it is very understandable for them where we are coming from. So, for example, I would say, like, what does she learn about pain from watching her mother? What does she think a good mother looks like? And maybe sound like, how far does she feel from that? And what is happening with her own relationship with the mother since the baby has arrived? Is her suffering wrapped in, shame before the pregnancy? What did the woman in the family teach her? Like, what emotions are allowed? What emotions are not allowed? What are you supposed to talk? What you're supposed to be silent and resilient? So these questions shift the whole formulation. It is not with the moms that what is wrong with her, but we are asking that what is she carrying? Where did it come from? That plays an important, and you will see in the sessions that it just opens up, it creates a safe place for the client to open up about her story. Next, as you see that this is the invisible load the mom carries. So look at the image. Like the one person is the mother. She's carrying the role of everything she's been given, like from wife, a daughter-in-law, daughter, immigrant, traditional keeper, professional, and the proof that the family hasn't failed. But the mother is not failing with so much invisible load, but the structure, the role is impossible to carry so much. So when we treat South Indian moms exhaustion, it is not as, I don't see it as a personal problem, but it is actually naming the structural, load. We are participating in that system that build the load. So our job is to say it loud that it is not weakness what you are feeling. It is the impossible architecture the system has made for us. And naming alone can be very therapeutic. Sometimes, the mom just wants to listen. Yes, I'm carrying so many duties. Oh, I'm carrying so many roles, but where am I? Sometimes just listening to this literally gives her a genuine relief. Now, as we spoke about postpartum depression, postpartum anxiety, it doesn't, it's missed constantly because it is usually said that that is how the moms are supposed to be. For example, hypervigilance about the baby. We say that it can be one of the symptoms for postpartum anxiety for a mother who keeps checking, oh, is my baby breathing? Yeah, so that is not considered sometimes as being anxious. It is, the family would say, oh, she is trying to be a good mother. Her family calls it, oh, the mother is so, you know, devoted. And that anxiety stays invisible. Second, you can see is that so I have seen in my practice that the clients are not able to express emotions, but somatically they try to say it a lot. For example, constant stomach aches, headaches, chest tightness. So when a client says that I get a stomach ache every time my in-laws are coming over, that is anxiety. And it just needs direct screening, and it is just not a note in the file. So why I am mentioning these examples? Because sometimes South Asian moms will come and sit with you with the symptoms saying that, I feel so tight in my chest. My head starts spinning. My stomach hurts when they are in a particular situation where they do not feel safe. So it is important to, you know, consider uh, these examples. Third is intrusive thoughts about the baby is kept completely secret because a good mother cannot think this way. And that is how, do you, we have to ask, like, do you ever have thoughts which you are afraid to say it loud? Does your body feel, tense most of the time? So these questions open up the door for to client to open up what actually anxiety means for her. We have the clinical knowledge, but sometimes having the cultural, you know knowledge where the client coming comes from makes a huge difference. Now, so when we see in our therapy sessions, as we know that uh, sleep plays a very important role. And, the stats have showed that most of the postpartum anxiety and depressive disorders usually show up because the mother does not get proper sleep. And it is very important to acknowledge it and work upon it. And I totally agree with it. So what we see in the therapy is that we work on how to create, mom gets proper sleep, how can she be compassionate towards her and not to quieten her, intrusive thoughts, talk about this. Those gains are real. But look what it doesn't say. For example, if your client sleeps better, but she goes back to her home, to a family that monitors everything what she does. So there is a constant, surveillance. There is constant thought that, I am being looked. So she doesn't get proper sleep, even though, she goes to bed, but she's carrying those thoughts with her. She feels compassionate about herself in the session, but she has to go back to a house that punishes, to be vulnerable, to show the emotions openly, and it is, not welcome. And her intrusive thoughts, they, of course, they decrease, but she doesn't know who is she outside these roles. So partial treatment of the whole system problems gives partial relief, no doubt about that. But these women deserve the whole thing. Why not? So this is the what so we have named what has been missing. So now let me give you something which you can take back. So this is the framework I use with every South Asian perinatal client. I built something because nothing else helped, because I felt these are very important dimensions to be covered. So it is the biological, psychological, socio-cultural, and the cultural lineage, which I say. So the when we say about the biological note, we work upon, okay, about the sleep deprivation. Why is the nervous system so dysregulated? Talking about the hormonal shift from, pregnancy to postpartum. So why it is so important we start from the biological thing is because a dysregulated body cannot do its identity work. No matter how much, we create a space, but if the client does not feel regulated, whatever we do, the client will not be able to relate. Next is the psychological node is the identity loss. We talk about, matrescence. We talk about the grief, who she was before becoming a mother. And because sometimes what I have noticed in the practice is that moms come and see, who am I? I was not, this kind of person before. So we have to psychoeducate what is matrescence and why these changes are happening. Where we say, literally, your brain as a motherhood shows a radical shift. The social cultural is like family surveillance, like, what is her family dynamics? Does she come, from a family, a single family, or she comes from a joint family? Who are the family members? Now, is when she, for example, I have clients who have moved from India to the US. So immigration plays a very important role. So does the isolation, because here in the US, the structure, the system is quite different as compared to back in India. So asking, like, what does the support system look like for her here? How to provide her the resources? And that's why with PSI resources, I'm really grateful to give them, the articles, for example, which come up, the support groups which come up for PSI. So providing these resources in hand is very important. And the outer ring, which you can see, is the cultural lineage. Everything, what I say, is transmitted, inherited, and enforced across various generations. So it's an invisible water the client has been swimming in. And this is where our standard care stops. And this is where what I'm talking, we need to go a bit further about it. So as you see that, here's what changes when we use the framework. You would see that in your session, we are not just targeting symptoms, we are targeting the ancestral wounds. We are not treating mood disorders in isolation. We are treating a person with a cultural system. And we are, working with the body. We are, not just offering insight. We are building clients' own capacity to trust herself and to find who she is. And the reframe at the bottom of the slide is one I want you to hold right now, is that recovery always does not sound like functioning again. Recovery is sometimes interrupting the generational patterns which we have been carrying. When a South Asian mom heals in a fuller way, she becomes the first person in her family line to know that her pain was real. She deserved the care, and it does not have to keep going. That pain, the suffering, the silence does not have to go. So sometimes we have to interrupt that so that the mom and the future generation do not suffer in silence. Now, this is the clinical architecture I usually follow. So this is a basic, it's just a structure. And we do not like have to follow like, oh, session 1 to 4, let's do phase 1, phase 2. It is just a structure to get an idea. And you can formulate it in your own way because you know your client the best. So I organize this work into three phases. Phases where we stabilize from session 1 to 4, like, building biological relational foundation so that the client and her body feels safe enough. That is very, very important. Like, I usually don't jump, oh, this is how you're supposed to do. Let's do some boundary work. Let's, use these scripts at home. No, because sometimes these things can trigger a lot of emotion and disrupt the family patterns, because that is why I said knowing where the client is coming from plays a very important role. Phase 2 uh, is that we work upon cognitive and cultural framing. So what we saw is the BPS cultural lens, biological, psychological, social cultural lens, for mapping her family role, like beyond these roles, who is this client? And that is why I call matrescence, and really grateful to Peanut, which got, lot of attention, what matrescence is actually, what actually means. And last phase is that we do the deep somatic work, like, working, for example, mother-daughter template, grieving who we are, and, and working on the somatic reclamation. So now, one by one, we will be going into a deep analysis, what each phase does, what does this framework does in deep. And if there are any questions which come up, please feel, free to share so that we can address this at the end. And yeah, let's go ahead with the phase 1. So the base of the phase 1 is actually sleep, and it is the primary clinical target in the first four sessions. It's not, no thought records or write a journal, do this boundary work, let's process this trauma. No, we just focus on the sleep and the safety of the client. If the body that isn't sleeping cannot do any work, please be mindful that your client's sleep plays a very, very important role. Now, on that base are the four things. That is the cultural cycle, psychoeducation which you give to your client. So, for example, it is important sometimes when the client is sharing their story and they say, oh, yeah, my mom did it. Yeah, my friend is struggling. So it is okay. So you have to pause the client and say that it is okay to struggle, and you don't have to be silent. You can talk about it. It is a safe place. But naming specifically why South Asian women's suffering goes, undetected, and there's a system problem, it is not a personal one. So that's why sometimes you have to give the words to the client where you feel like, for example, it is okay to struggle. It is okay to feel sad. It is okay, to grieve the journey which you are going through. But that is why the space is here to provide you a safe place. And next is safe disclosure. So working against the belief can, for help is an admission of failure. So this takes repetition. You have to disclose that it is okay to talk about, what you are struggling during your pregnancy or postpartum or motherhood period. It is not a sign of failure. It does not mean that you are not good enough. It is okay to feel because you are carrying a lot of things in your chest. So it is important that we name it. The the third one I would say is the medication conversation. Directly separating the choice. So it is always your client's choice, to take a medication or not. But as a duty of a therapist is to psychoeducate them about the medication and refer them to a psychiatrist if they are comfortable with. Because there is a lot of stigma attached to medication. For example, oh, I cannot breastfeed if I am on SSRIs. I cannot if people will think there's something really wrong with me. So these questions, the moms sit with a lot of doubts. So as a therapist, it's our duty to break those stigmas and talk about it. And at the end, it will be always your client's call that if they want to go ahead with the medication or not. Lastly, we work upon the nervous regulation, that is grounding, breath work, and we will not tell that, oh, this is your homework, this is what, use this meditation technique, use this breathing technique. No, we will tell them these are like the tools which help you to feel safe and navigate it, to get in touch with yourself. Next, we move on to the phase two, which is the cultural formulation and the identity work. So, first, you name the pattern, what the client is going through without blaming the family. Now, clients would show up saying that, oh, my in law said this, my husband said a particular thing. Yes, so we do not directly go and say, oh, you should not take it. And the why I'm saying that, because sometimes in the South Asian family, that can, you know, lead to divorces, which I have seen. So suddenly, keeping these boundaries can, create an environment for the client later when she goes back home by not feeling safe. So there's always, you can name the pattern. For example, your grandmother who survived through silence, she was not wrong. She gave you what she was given. So validating these patterns plays a very important role. Second is the Matrixon's framework. Now, becoming a mother is an identity upheaval. It is not a disorder. So you can say that, this, because as we have seen in the previous slides, that the moms are carrying a lot of generational roles. The traumas has been passed. There is this invisible load which they have been carrying. And with all these pressures around, the mom is like, who am I? So it is important to psychoeducate what the word matrescence means. That means you haven't, lost yourself. You are becoming. And that's a beautiful journey in its way. It looks like something which I don't know who you are. And these questions stand absolutely valid. And this is why we are here in this space to explore more. Now, distinguish the love from self-erasure. That means that your duty does not mean that you have to feel depleted in this role. You respecting your elders does not mean that you carry the fear. So these equations have been quietly running in their lives. So naming them explicitly, I have seen gets a lot of relief in the clients. Sometimes they just want to hear that, the roles they have been carrying and the exhaustion of motherhood does not mean that, it is to be depleted. The respect, sometimes they keep respecting everyone out of fear, like what will the people think? So it is important to keep these, things in mind. As I told about boundaries, you have to build boundaries which are culturally survivable for the client. For example, your client comes up and says that, my mother-in-law is doing some giving me advice regarding breastfeeding or body feeding. So just tell your mother-in-law just to stop it. That is now it's not going to work. So what this does it actually causes rupture. Instead, you would ask question like, what would a 5% less feel like? It looks small, but it looks, the client can survive. Like, for example, instantly of saying no, how to put up your thoughts or your views as mother so that the relationship does not rupture and the client does not lead to a situation of severe distress. Now, the phase three is like 11 session plus, which is actually the deep work which we, build. That is like, rebuilding maternal permission. Now, as we have seen that the client might have spent so long, serving others, she feels lost with the sense of her own needs. So we can keep the questions with the client, such as, what does it feel, to let someone else hold, this 1 hour? This 1 hour is for you. This 1 hour of session, it allows you to speak whatever's there in your heart. This is your space to talk. You don't have to suffer in silence. Second is what I usually do is work on maternal identity, that I bring the old self, the cultural self, and the maternal self, and not like choosing between them. So, like, I would be like, okay, so who were you before being someone's wife or a daughter-in-law or mother? And many clients have never been asked who she actually was. And trust me, it does wonders because, the client sometimes wants to come out of it and be like, who am I out of these roles? Let's talk about that. The grief of pre-maternal self. So, in South Asian cultures, once you reach the phase of pregnancy and postpartum, it is said that be grateful your child is alive. People are struggling to get a child. But grieving what your client is going through is absolutely okay. Dismissing what your client is going through, that grief, is not okay, I would say. So it is, naming the grief is important. Pregnancy and postpartum, we highlight as is to be very beautiful, joyful. But sometimes there would be people out there who are having a tough time navigating this phase of life, and that is absolutely okay. And this grief is valid because sometimes the client would say, oh, this person ABC is able to handle, why can't I? So, naming the grief plays an important role. Processing the mothering that she didn't receive through letters, open dialogues, or through storytelling, which I would say. And lastly, embody the safety, sleep, and emotional naming as a core clinical goal. Like, focusing on that should be one of the main criteria. Now, coming to this, defining maternal body fullness. So, I want to talk about this because I have, you know, uh, seen that this tool is been very helpful. So the definition of what maternal body fullness means, you create a culturally safe somatic practice that helps mother return to the body as a place for permission and emotional truth, not just as a place for, labor and duty. So as you see, now we keep on hearing about mindfulness and how important the role plays, and how does this distinguish between maternal bodyfulness is what I would like to focus a bit about. So our mindfulness tools tell us that you observe the body from a slight distance and see what it is trying to tell. But the maternal bodyfulness tells that body is not the object. It is a source, and it is not to be watched, but it has to be go inside and see what it is trying to tell. Because for South Asian mothers, bodies have been in service for years and years, like before even getting married, before, like, as soon as they're born, there have been various roles. So it is fundamentally different orientation. So this maternal bodyfulness is like returning to your home. It can be through somatic experiencing, sensory motor psychotherapy, or a therapeutic presence with a cultural context does lot of role, because we have to give the client that safe space in her own body. Next is this is the few tools which can be used. For example, like where does this expectation live in your body? For example, the client says that I don't feel good enough. Though you would see that she will name the pattern that she is doing a lot of work, but she's like, I am not appreciated enough. Why I feel like a failure. So we work upon, the tools such as contraction versus ease mapping. For example, you track the body's response to specific people or situation. And for example, when you say your mother's law name, what happens in your chest? What happens in your stomach? So your body always answers before the mind edits, because that is why I focus upon the generational scripts we carry, because sometimes our mind is very rewired. Okay, let's edit this. This is not how it's supposed to be. So focusing on these questions does beauty. Now, hand to heart grounding is you place one hand on your heart and you feel it breathing. And that is, the body working for you. Sometimes just connecting it to the present gives a safe space to the client. Tool three is culturally, resonated sensory rituals. Uh, when you see your client have signed up for you, do study a bit, for example, or maybe in the sessions you can explore, for example, having a cup of tea, a prayer, what safety means to them, even though it can be very small, but what the client can use in their particular week to feel safe and connected with themselves. Then this is very important, embodied rest without guilt. Because in South Asian population and with my own journey myself, I have seen that if you take rest, you are not grateful. And like if you just go and take a nap for 20 minutes, you might, family members might end up saying that, oh my God, who will see the kid? You're supposed to do XYZ chores of the house. So please psychoeducate the client that this guilt needs to be, removed. Try her to connect with what rest is, because postpartum body and trust repair plays a very so you have to tell that you grew a person, a living being inside your body. And your body is not a machine, like, let's press this button, do this thing, press this button, let's do this. Respecting the body. Your body is not a non-living machine, but it is actually a source to provide for yourself first and the others in the family. Moving on. So, where does this expectation live in your body? That insight is very valuable. But a client can understand everything and still feel nothing shift. But she knows she doesn't have to be perfect. And she might still feel like, am I good enough? But when we ask, where does it live in your body? We move from the story into where the wound is actually is. So, yes, that is why having a culturally informed training plays a very important role here. So, the South Asian healing lens, I have divided into emotional and relationship skills and the bodyfulness skills. For example, why? Because these two pillars, they develop together. You cannot do deep somatic work in a body that doesn't feel safe enough. And you can't hold relational or identity gains without body as a partner. So each one of this is dependent on each other. So the family role mapping is one of the useful exercises I have seen that we sit with the client, we list the roles she holds, not just as mother, but as wife, as a daughter-in-law, daughter, a traditional keeper, professional. We put all them on the paper. Then two things. We look at the cost of each one, not the social cost, but the internal emotional cost which she is carrying. And what does it take out for her in this role? And we separate those roles from the inherited ones. So the role she's actively chooses, so you have to find the roles which she chooses because that actually gives her the energy to survive. And we separate with the inherited roles or the scripts which we have been given from, generations. We divide them and we identify every role and choose which needs to be chosen, which we need to let go. So, what does maternal healing actually means is that there are three things I would like to say. One is lineage aware, to hold where your client comes from, not where she is. Her suffering is an individual. It is the end of the long generational trauma she has been carrying. Secondly, culturally believable. The path forward makes sense inside her world, understanding where she's come from, and it has to work for the life she's actually living. And it is embodied, that it reaches the body, not just the mind. That's where it lives. So healing in South Asian moms is, doesn't mean that you dismiss her, that she's being too emotional or too dramatic. It's honoring, the body's wisdom and releasing the invisible weight the client has been carrying. So it is helping them so they feel less burdened by these inherited expectations that were never meant to carry alone. The isolation of and not having the own village, it takes a toll mentally. So, and motherhood was never supposed to be done alone. Maybe you did not get a village from your own family, but you can always help the client to build her own village with the resources she has, providing her the resources which are available to her. So, yeah, just to put the framework in the summary, what we have spoken is that we go for the assessment by, focusing on the biological, psychological, cultural lens, where's the client coming from. Our intervention is maternal body fullness and the somatic practices. And third is the treatment structure, where we go through stabilizing, formulating, and working on the embody and repair. These are the various resources which I used. And yeah, so I hope it gave an idea about, if you come up with a client uh, who comes from a South Asian population, I believe that this would be really helpful to understand more about the culture and where they are coming from.